because with the X-rays we have tough time, but she has extra tools, and we are eager to listen.
Okay, thank you, Chairman. Good morning to you all. Thank you for having me to this important meeting, and I'm honored to open this section. I'm here to talk about chordoma treatments at CNAO. So, sorry? Yeah, perfect. Okay, thank you. Okay, chordoma is a rare tumor, well recognized as a radio-resistant tumor with locally aggressiveness and slow-growing behavior. The common site of origins are sacrum region, more than 50%, followed by skull base and mobile spine. As you can see on the right side, the typical presentation at the moment of diagnosis of chordoma in different sites. In skull base, mobile spine, in sacrum, where peculiar aspects are the proximity to the structure deputed to the relevant function. It goes, we can see the skull base, chordoma, brainstem, and optic pathway, spinal cord, kidney, and bowel in mobile spine, cauda equina, nerve roots, and bowel in the sacral region. This is why the therapeutic strategies are still challenging for this tumor. Anyway, surgery remains today the main therapy, and is largely demonstrated that complete resection, R0 for skull base, unblock resection for mobile spine, and wide margin resection for sacrum are strongly improved local control and disease-free survival. Considering the typical presentation, complete resection is not always possible in these regions, so radiation therapy has a good role, important role in therapeutic strategies, particularly particle therapy, because they are radio-resistant tumor, because high doses are required for improving the local control, for overcoming the dose limiting the structure of this reason. So for this complex and large tumor, the scalping of the dose distribution of biprotons and carbanions are necessary. Nowadays, the use of particle therapy is well recognized in international guidelines. You can see the last guideline, European guidelines, as of 2021, where EV particles should be considered for radio-resistant tumor. And as well in American guideline, the last NCCN, protons and carbanions radiotherapy are recommended. In our center, we started to treat chordoma patients from 2012, and we have 2 particle beams available for clinical activity. In general, our general approach in a curative setting is to use high-dose proton therapy for surgery with microscopical residual, and high dose of protons or carbanions in case of macroscopic residual after surgery, or advanced tumors not suitable for surgery. Of course, we have to take into account the different regions for different approaches. So we are analyzing chordoma treatments by site, starting from following the anatomical line. We start from skull base, where surgery is the first recommendation, with the safe resection or separation from the critical structure, followed by adjuvant radiotherapy. Adjuvant radiotherapy in skull base is well indicated even in R0 resection, and high-dose particle therapy is strongly recommended to overcome the dose constraints of or critical organs, particularly for brainstem. You can see the selected series of our literature based on high number of patients with high local control and overall survival, patients treated with proton and carbon ions radiotherapy. Among these cases, this series, we have our contribution. This is our prospective study recently published, where we collected 135 patients treated from 2012 to 2018. 70 patients treated with proton therapy, 65 patients treated with carbon ions radiotherapy. With a median follow-up of 4 years, we achieved a good local control and overall survival, consistently with the results of literature. We see a little bit less results with carbon ions, but we have to consider that we treated with carbon ions patients with worse prognostic factors. These are the most important criteria which choose carbon ions than protons. So macroscopic disease, larger GTV, and worse prognostic histological characteristics as the differentiated subtypes or high proliferative index, or proximity to critical organs with compression of brainstem or optic pathway. There is another reason we choose the carbon ions, not only because radioresistance of the chordoma, but also for the steep dose gradient. This is our previous dosimetric evaluation, where you can see in proton plane the dose falls down with in 1 centimeter from 70% to 36%. In carbon ions plane is better. You can see in 1 centimeter the dose falls down from 100 to 22. This peculiarity is very important also for the mobile spine treatment because of the spinal cord. Is a very critical and important organ. So let me introduce the mobile spine treatments. Okay, in this region, the surgery remains the first therapy, and block resection is well recognized, giving the best results in terms of local control and overall survival. But the typical presentation is frequent with intracannular invasion. So the spinal cord is very limiting for surgeon and radiation oncologists too. In this case, is also recommended particle therapy with high dose over 6 or 66 gray after separation surgery. Nowadays, separation surgery and followed by particle therapy is recommended for avoiding disabling surgery. This is the literature background, and you can see in the past we found more paper using mixed beam photon and proton therapy. In the last year, we started to see also paper with treatment with carbon ions therapy in this region too. This is our preliminary outcome, still under evaluation. At CNAO, we treated 64 patients, all patients with carbon ions radiotherapy, and we achieved a local control at 2 and 3 years, quite similar to the previous studies. We have to consider that in our series, all patients had macroscopic residual intracannular site, so very difficult to treat, very difficult to overcome the dose limit of spinal cord. The overall survival is consistent with literature. This is one of the examples and our best results in cervical chordoma in a young man after separation surgery received carbon ion therapy. And you can see on the right side, the red one, the contouring red one is the macroscopic residual after surgery, very close to the spinal cord. And we optimized the dose. We overcome to better with over the limit constraints. And after 5 years, this patient is in a good clinical condition. So we can say that in skull base and mobile spine treatment, they have a common characteristic where surgery and adjuvant high-dose particle therapy are recommended. It is very important, a strongly cooperation between radiation oncologist and surgeon since the preoperative phase, because we have to take into account perspective prognostic factor from surgery and radiotherapy, the possibility of reconstruction in case of skull base or orthopedic stabilization in mobile spine. And this is very important because where is expected the necessity of metal implants, we have to discuss with the surgeon the geometry and the type of metal implants, because we know that titanium strongly interfering with those covering and was covering the dosage. Okay, so sacral chordoma. Sacral chordoma is very interesting for hadron therapy because more than the other side, we find large asset diagnosis. More patients are not suitable for wide margin resection, so 4 patients are candidated for carbon ions radiotherapy, hadron therapy in radical setting. Of course, I'm talking about carbon ions because it's mostly used in our center for radical setting of radioresistant tumor. The carbonide, usually the patient not suitable for surgery are patients with large extension of disease up to S2, S1, where you can see the permanent urinary rectal dysfunction are for sure after surgery, and the high risk of sequelae, late sequelae in are quite sure, and mostly in different situations the patient can choose the treatment, and sometimes in the last years the patient more frequent refused surgery to find and to find an alternative. We have 2 important studies for definitive treatment for sacral chordoma. The study in 2016 from Japanese center. This is an important milestone for this treatment. They achieved a good local control, more than 77% at 5 years, a good overall survival with the lower toxicity. Another important study is from a multicentric study from Japan as well. You can see high number of patients treated in a definitive setting for sacral chordoma, and in the same good results. In our center, we started to treat chordoma with carbon ions in 2013. We treated 163 patients with definitive carbon therapy. 61 patients were excluded because enrolled in international protocols, and 10 patients excluded from the analysis because follow-up less than 1 year. We consider this factor because we consider the slow growing of chordoma, so we have to have a good time and follow-up to evaluate the real time of recurrence. 6 patients were lost to follow-up, so we analyzed 86 patients. Okay. These are our results, and we can see 2 years local progression-free survival is quite higher, less after 3 years, and with good results on overall survival. So, what we can do for achieve better results? Of course, we have to consider expected learning curves with an improvement over the years due to the increasing collaboration with referral center, due to the improvement of treatment planning system, with better knowledge of LAT and RB distribution, and the biological model, giving us the possibility to better optimize the dose and better know the possibility and the potentiality of carbon ions. We started analyzing the pattern of recurrence, and we found in field recurrence more in pararectal sites. You can see this is a typical case treated in our center in 2017, and after 2 years we saw a reduction of the disease. The red, the light blue is the mass after 2 years. After 5 years, we still see the reduction of the big mass treated, but pararectal nodules appeared. So, back to the plan, we saw a very good dose coverage for this patient. So, we find motivation of this recurrence, and fortunately from 2019 we are comparing 2 different radiobiological models, LEM versus MKM. We recalculated the plan, and you can see in the lower slide this is a new calculation with the new within MKM radiobiological model. So the first treatment were not really well covering from by the high dose. So another important factor to overcome the limit of dose constraint, bowel dose constraint, is to implant a surgically the spacer between bowel and the chordoma, to better cover the tumor in this area and avoid the possibility of recurrences. So I'd like to mention 2 important prospective studies ongoing in our center. This is the first randomized and observational study comparing the surgery versus radiotherapy alone, and you can see in arm B, where definitive treatment patient enrolled, the 90% are treated with carbon ions. The results of this study are ongoing analysis. In the last meeting at interim, we find quite the same results in terms of local control and disease-free survival between surgery and carbon ions radiotherapy. We are waiting the definitive data to be published. Another important prospective study in collaboration with Mayo Clinic is a comparison between treatment of pelvis sarcoma between carbon-lens radiotherapy, proton therapy, or surgery followed by radiotherapy. You see in this all center with activity with carbon ions activity are participating, and these studies are very important because in a new area where the indication for sacral chordoma are changing, these results can help the community to define the right indication for some radioresistant tumors. So in conclusion, we can say that the better treatment for skull-based mobile spine is a maximal safe resection followed by high dose of particle therapy. For sacral chordoma, maybe definitive high dose of carbon ions radiotherapy can be an alternative to disabling the disease. The low dose coverage is important for the improvement of local control, and we are work in progress to optimize the radiobiological models and to discover the other potentiality of this new particle. The multidisciplinary discussion, the expertise team is very important to face this difficult disease, not only chordoma. So I'd like to conclude saying that working together makes a difference. Thank you.
Thank you very much. You guys have any questions? Paolo?
Thank you so much. Yesterday we have seen the results comparing proton and carbon ion, and you see some problems with LM model, yeah. And today you show a similar situation, yeah. You use MKM model, and it show up that there is a bit different planning done. What will be the consequence for your treatment planning? Are you changing something now in using, because LEM model and the system treatment planning system has certification? Yeah, using this. Do you plan to make an action for other localizations?
Yes, of course. We are in this moment we are changing the two models. For now, we have two radiobiological models available to do the comparison. We started from with the big mass because we had the more possibility to see the differences and to recalculate the doses, because is very important, because we see that in this case, in another case, up to now, we are recalculating almost 25 patients, and the doses are different. I have to prescribe with MKM lower dose. So this is a very important point, because I think, according to our director, the next phase will be an amendment of changing the new model to use to do the plan, to do the clinical activity with the carbon ions. In another, we are trying in spine tumor, but not only in big volume, and not yet in a small volume.
Just a very small comment. It's microdosimetry is unique with radial dose distribution.
Sorry?
I also have a question, if you don't mind. So these are all primary tumors, right?
Yeah.
How was the follow-up for metastasis or anything? Did you achieve any follow-up, long-term follow-up in the sense?
Just, okay, so the patients are followed, of course, for follow-up, and we have a very low rates of distant metastasis. It's more frequent local regional recurrences, more in gluteus or in acetabular region or pararectal site.
Okay, great. So in the interest of time, I think we'll continue. There was a comment in the chat. That's not a question. It was a praising comment. Good job, appreciation. So thank you very much. Okay, thanks.
Okay.
Just one more minute, please.
Yeah, here closes the session in this room, but I just wanted to remind you that in the main auditorium, Professor Roberto Orecchia and Arnold Campos are giving a presentation in the framework of the Aristotle Medical Forum in the session of the role of artificial intelligence in radiation therapy. So I encourage you to just step in the main auditorium. Thank you very much.